Hello, my name is Sasha Jovanovic, and welcome to today's lecture on soft tissue aesthetics and health. I'll be focusing today on the 10 key factors in soft tissue management, and especially those key factors which I've learned to be of importance from a standpoint of biomaterials, so implant components, as well as those procedural guidelines which are a balance between biology and clinic and how we really work with patients. This is something which is of importance in everyday practice, and it plays a role with every day that I'm working with patients. First, I would like to give a little bit of a background and a philosophy of what we're really working with. So the implant soft tissue success story really focuses on 5 key points. And those are that, like when we work with soft tissue, it's really a team approach. Think about how we started with implantology and osseointegration. It was the surgeon and the prosthodontist and the laboratory technician. It's nothing different today. We always have to think about how can the team work together. And for soft tissue improvement and management, we often work on the same day together on the patient's therapy. And secondly, it's the science behind all of this. There's an enormous amount of science which is coming through to us every day on the part of implants, on the part of abutments, on the part of grafting materials, on the part of just procedural guidelines for us. So protocols are changing every day, and that's really important for us. And of course, the scientific breakthroughs make things more efficient and more predictable for patients. Then it's the skill level. We all have our certain level of skill level, and of course we have to also be realistic to what we can achieve for our patients. Therefore, each clinician needs to know what he or she can do and when it's a good time to look for another expert to help them with their patients. Then fourthly, it's the experience. We all learn over time, and experience doesn't mean like we do 1 and that's enough, or we do 10. Sometimes, unfortunately, really experience means we need to do hundreds of cases before we really become efficient. So experience is just something we gain every day, and we make it better and better and better. And sometimes we say we won't get as good in experience till we do a couple of thousand. Of course, that takes time. And then we go through training and continuing education and professional development. And that's, of course, what we're doing here through these kind of lectures, where you can learn and really bring up as much as possible. So those are, for me, the implant soft tissue success points which are important. So now let's go into the clinical aspect and see what really have we learned over time. Well, first, we can talk about what were the success and survival criteria for implants. And when we go back to some of the really well-known success criteria which were established by Albrechtsen back in 1986, it's very important to see that everything was about the implants and about the bone and about the patient's quality of life. Not so much was about soft tissue. But one key point we really learned quickly was that the crestal bone loss or the crestal bone stability was very important. And Albrechtsen already back then established that we should have a minimal amount of crestal bone loss to really have stability in health. And that translates today for us stability in soft tissue. So there, Albrechtsen helped us a lot. Then, a few years ago, I published in the Journal of the California Dental Association a paper which I went more into success criteria which were clinical based. And really there were again 5 points which I felt were important from a standpoint of bone, soft tissue, as well as implant prosthesis or implant aesthetics. And as you can see here, in those 5 points, 1 being bone, 2nd being the implant choice and position, the middle one, which is the 3rd one, is right there, which means the importance is soft tissue thickness and soft tissue quality. So what's important for us today really is like how thick is the soft tissue, so the volume, and also how is the quality. So is it keratinized, so it's nice and dense and attached, or is it potentially loose and alveolar mucosa? So those are important criteria we have in soft tissue. And then we go on with point 4 and 5, which really have to do with the abutment design and the prosthesis. So you can see that over time, success criteria are changing, and we're using them. But soft tissue today is really very important for us. So then, in the late 90s, which was towards 97, 98, I published some articles which were focusing on new clinical protocols. And those clinical protocols were about how to place an implant and how to deliver that implant position so it can really give us stable bone and therefore also stable soft tissues. And what came up in those early protocols was that we need an optimal three-dimensional implant placement, which means optimal buccolingual, mesiodistal, and optimal angulation. But then very important, something which was not discussed yet, was the vertical position. And in this protocol, what's important is that the neck or the shoulder of the implant is placed in a proper vertical position. And the proper vertical position is approximately 2 to 3 millimeters below the optimal crown margin or the optimal gingival margin. Now, what that often means is that the neck or the shoulder of the implant is somewhat outside of bone. And therefore, in this protocol, we need to also add that we have to do augmentation of the crest through ridge augmentation, or that we have to add connective tissue grafts to thicken the volume of soft tissue. So the clinical protocol calls for 3 steps. One is optimal implant position, often a bone augmentation, and or a connective tissue, soft tissue augmentation. And that's the protocol. And you can find these papers in the PPAD in 1997 and 1999. And to give this better to you as a clinical example, you'll see here a clinical case which we did back in 1997. And it has now a follow-up of 14 years. And here you can see a patient who had a central incisor, number 8, which was hopeless, and we had to extract it. But the gingival margin of number 8 was more apical than number 9. And the patient, which was designing a tooth replacement for number 8, really asked for the gingival margin to be exactly the same like number 9. So somehow I had to move the gingival margin more coronal. So that's why you see in the left photograph the position of the implant to be more coronal. And therefore, it is about 2 to 3 millimeters below that ideal gingival margin that the patient desires. But it means, of course, that the crest of the bone is missing. So the shoulder of the implant is exposed. And that's why you see the development then which comes from bone augmentation on the right 2 photographs. And here you can see in the middle photograph basically what we call the buccal bone balcony, or the triple or the 3 Bs. And this is really done so we have a good contour for the radicular form of the soft tissue. And on the right photograph you can see that crestal augmentation achieved here after a GBR procedure, after an uneventful healing period of 6 months, where you can really see how this bone now actually really will support the soft tissue. Now what happens? You can see here. 1997 on the left side, just prior to extraction. Next photo over, 1997, the finished all ceramic crown. And notice how we were able, through proper soft tissue management and through an excellent restorative work, to get the soft tissue margin to be the same. Now notice what happens to 2004, 7 years later, that the soft tissue margin has established itself and is stable and predictable. And 7 years later, now 14 years later, we're looking still at a reasonable, stable soft tissue margin. It's a little bit maybe moved and changed, but it came because the crown actually fractured in that final 7 years and had to be replaced. But look at the lower right photograph where you can see beautifully how the x-ray of this patient 14 years later shows beautiful crestal bone stability. So here is the 14 years case example of this patient, where you see on the left side, you see the photograph which shows you the 1 year clinical stability, and on the right side, you can see the 14 years later bone stability and gingival stability. A beautiful case to demonstrate how this clinical protocol can really work for the patients, perfect as well as excellent gingival support. So then today, we can really say that implant aesthetics has evolved. And I would say it has evolved since 1997, since those early days of that clinical protocol. And now it's standard of care. We can do it through optimal aesthetic implant position and bone and soft tissue augmentation techniques. And then we can get to cases like this, where we can really bring back a smile design which looks invisible really to the patient and invisible to any other viewer, that the implants are as good as natural teeth. So this clinical protocol has become extremely important to deliver this kind of predictability to patients. Now let's look at some clinical conditions which are, of course, also giving us other options. On the left side, you will see here a patient which we treated with 2 implants in the central and lateral position. And we didn't do much grafting here in this particular case, and we ended up, as you can see here, with an implant prosthesis which was still very acceptable, but as you can see here, it was treated with a pink porcelain prosthesis. On the right side, we did also 2 single implants. They both went into the center incisors, but here we used grafting, and the grafting was done in a staged approach. We did a before implant placement, so I did a bone graft here first, then we did it simultaneously with the implants, and then we went through the normal phase of temporary as well as final restorative treatments. And you can see when you compare these 2 patient results that they're both beautiful from a prosthetic standpoint. Both done really excellent from the prosthodontist in both cases. But it's a little bit different because the left side, of course, is laboratory gingiva by pink porcelain, and the right one is natural gingival aesthetics. And it is, of course, the right one which most patients will emulate to when they're asking for our treatment. Although the left one is certainly an option for patients, and it sometimes will take less time, and of course less budget, and less procedures to get there. But of course the downside is that it's really not the natural aesthetics which patients are looking for, and maybe also another downside is that for hygiene purposes, it can sometimes be difficult to keep this perfectly clean in these difficult prosthetic rehabilitations. So now let's move to other types of conditions which are important for us when we do surgery and we think about soft tissue. When we think about soft tissue, we want to have basically that the soft tissue doesn't look that we touched it. So on the left side, you see an implant rehabilitation on the lateral incisor on number 7, which was done flapless. So we didn't make any incisions because the bone and the soft tissue conditions were so good. On the right side, you can actually see the patient who had an implant rehabilitation on number 9 on the central incisor. But here, we did do a GBR bone graft and we did a connective tissue graft. But the point here to make in both of these cases, that when we think about implant surgery and when we think about soft tissue work, it really should be invisible to the patient's eye and of course to any viewer. So if we do grafting or we don't do grafting, it should both be invisible. And it is possible today when we work with incisions, when we work with proper protocols, which we have today. The next condition, which is often discussed, is really what can we do when we need 2 implants next to each other and we still want a proper soft tissue framework. Well, very often it is said that 2 adjacent implants we can't really achieve proper soft tissue gingival papilla. But when you look at this particular case, this was a patient which had a trauma, and I had to do a staged vertical and horizontal bone augmentation first. Then we placed the implants and we did some more soft tissue grafting. And you can see here with optimal restorative care and good implant position and augmentation, we can actually have a soft tissue profile which really looks quite good and natural. So it is not always the case that we have to kind of conclude that 2 implants next to each other don't get a good soft tissue aesthetics. It's more the proper protocols, it's more about the proper implant position, proper augmentation procedures, and of course proper restorative protocols. Once this all fits and the patient fits into this as well with a good profile, we can actually get very good soft tissue aesthetics like you see in this patient. Here's another example. In this particular patient, we placed actually 3 implants and 2 of them were adjacent. Now, with this smile makeover, which was done here by colleague Frediani, you can see here that the anterior really looks almost perfect. The ceramics is beautiful, the teeth and the tooth design is beautiful, and you can see that the soft tissue margins are also very good. So where are the implants? And when we look at the two adjacent implants, it was the lateral and the central, the number 7 and number 8. So we're able again, through proper implant position and through proper augmentation procedures, and of course excellent restorative work, to get here a soft tissue margin which is at the right height and to have a soft tissue papilla which looks normal. So from this patient's perspective, we were quite happy to get this result. So then it leaves us with the last question really, and that is, can we really do edentulous cases properly? And can we really get soft tissue margins and soft tissue papillas to grow back? And those are very difficult. So here you can see a patient which I use as an example here, where we actually were successful. You can see that the soft tissue margin from the posterior all the way to the anterior is quite within normal range. You can see some full soft tissue papillas, and you can actually see a nice profile in this full edentulous rehabilitation. How do we do this? Can we apply these implant protocols for single teeth also for edentulous? And the answer is yes. And here you can see the x-ray the way we started in this patient. And you notice that in this particular patient, she was semi-dentate with some hopeless teeth, and the posterior bone was collapsed and with large sinuses. So what we had to do here was, first of all, regenerate the posterior in a vertical direction, graft the sinuses, and then the anterior we preserved. So basically through socket bone grafting and some connective tissue grafting. And this in the end gave us the opportunity to place implants across the maxilla and make 4 3-unit bridges, which gave the patient really an appearance and a soft tissue profile, which was very good. So from a soft tissue standpoint, this was even successful in an edentulous case. Now we have to be realistic that this is not possible in each case. So not every edentulous maxilla we can do this, because many of our edentulous maxillas have a lot of resorption, and to really gain that perfect amount of vertical and horizontal bone is not always possible. So you have to kind of see that it's in the right range of possibilities within the patient's diagnostics and also in the patient's protocol. Now let's move now to the basics of soft tissue. You've seen now a couple of examples of patient cares which all look that the soft tissue is possible to really almost regain that perfect aesthetic look and the perfect gingival margin look that we need for patient care. So how do we get there? And the first thing we need to do is go back to bone. And what you can see is that the implant soft tissue success is really based on stable crestal bone levels. So when you choose your implant design, when you choose your implant system, make sure that you choose an implant design and system which really has documentation that it can preserve that crestal bone. So a maximum of 2 millimeters of bone loss is acceptable from a clinical success standpoint in the first year. And then after that, it basically should be stable. We don't go back to the Albrechtsen criteria that it should not be more than 0.1 millimeters per year. That's it. And we know that this works. You can see that we have done this in the posterior. This here is in the posterior, 3 Brandemark implants, which show after 10 years an absolutely stable crestal bone. Now imagine, the soft tissue on this will be stable as well. So now we just take this story of the posterior mandible, reverse it, and just put it in the anterior maxilla, and in all those areas where it's important for us to have stable soft tissue margins. So that's what we do. So then what comes on top of the bone is really, of course, then the soft tissue. And the soft tissue is then the biological width. And you can see here that the references, the literature references which go back, are now almost 20 years of perfect aesthetics based on soft tissue stability. So we have here studies which have shown that the soft tissue dimension around implants on top of bone is stable at approximately 3 millimeters. So now you can see that bone, of course, is now maintained by the implant, That's the studies which we have seen, the long-term documentation. And the soft tissue comes on top of the bone. So soft tissue margin is based on the bone level. Bone level is based on the shoulder of the implant or the neck. So those three go hand in hand, and they give us the stability. Now there's some excellent studies in the literature, and I've picked out one which I particularly think is good for this understanding of soft tissue. And you can see the soft tissue dimension around implants. And it's interesting, when you compare a two-stage system with a platform switch or a conical connection to a two-stage system with an hex and a slightly enlarged abutment versus a one-stage system, if you do not disconnect the abutment, the soft tissue dimension is stable and it hovers around the 3 millimeters, making us to conclude that basically soft tissue around most implants, as long as we don't traumatize it, will stay stable around 3 millimeters. And that's basically what we can use today when we place the implants. And that's why today we place implants no deeper than 3 millimeters below the soft tissue margin. We're basing it on these kind of studies. So that leaves us then to finish the soft tissue story with the gingival papilla. And there's a beautiful reference here which was made by a group from Austria which showed us that we can use pink aesthetic scores as an analysis for soft tissue success. So the first thing which you're going to look at is really, is the soft tissue margin the same between the natural tooth and the implant crown which you're trying to replicate? And that's really something which we're basing on that soft tissue dimension. So when you look here at the margin, which you see here, you can expect that the implant is approximately 3 millimeters below that and no more. So that gives you then also an idea of where do I go with the papilla. Well, the papilla is on top of this. And we know from further studies, especially from the NYU group, that these gingival papillas actually are hovering at a maximum of about 1 to 2 millimeters below that soft tissue dimension. So that means the total soft tissue papilla in the interproximal space can be about 3 to 5 millimeters. 3 millimeters, the normal soft tissue dimension, plus an extra 2, which we can gain in the embrasure space. So that's what you see here. So then we can make safe protocols again for the gingival papilla. And I've come up with this protocol which kind of goes into 2 dimensions to make it like easier for us to use in clinical practice. First of all, I'm thinking about the horizontal dimension. Think always about the distance between implants and think about the distance between an implant and a tooth. So the first distance between an implant and a tooth should be no less than about 2 millimeters, and it could be more. Now sometimes we can go less, but you probably have to have a little bit more experience to really do this. So 2 millimeters is about the least. And then between an implant and an implant, we should have at least 3 to 4 millimeters as our safety zone. This will support the bone, and again, the bone will support the soft tissue. Then we go to the vertical dimension. Now the vertical dimension, as you can imagine, again, we know that we will get soft tissue thickness 3 millimeters on top of bone. But if you are in a right embrasure space and you have sufficient space between a tooth and an implant, or you have enough space between an implant and an implant, you can actually go up to 5 millimeters because of the embrasure space. So minimal papilla will be the same like the buccal gingiva, which is no papilla, or it could be a maximum of 2 millimeters, which would be something which we would accept as a very, very good success in clinical practice. So that's our gingival papilla. So now we come to a conclusion, really. How much of this becomes successful to us? Well, the truth is, as long as we work in the functional area, we're very successful. So you can see that here. 95 percentile of success and predictability we get with implants when we just look at restorations. But once we go to aesthetics, which means stable soft tissue margins, it drops down depending on the study we go with. And I'm giving you here a reference which is quite low, but it's good to always start from this point. And here you can see about 60% only is fully successful in soft tissue margins. So here you can see an example of a patient which I did about 20 years ago, which functionally is still successful. But soft tissue-wise, you can see the implant crown is too long, so it shows soft tissue recession. The gingival papillas have receded, and the incisions are still visible. So it kind of did not really follow the success protocols of soft tissue work. So today, luckily, with our new protocols, we can get to things much better, and we can get to results much more predictable. So here you can see a patient which actually shows a very beautiful number 8, which is almost the same like number 9. So number 8 is an implant, number 9 is a natural tooth. And you can see the soft tissue margin is similar, the gingival papilla is similar, it's a high smile line, and we can really give this. And if we follow good protocols, we can get as high as 95 percentile again to get good soft tissue aesthetics in the right patient. So today we know the soft tissue story, and I hope that with these kind of protocols you can use that in your own practice. So now I've summarized this for you in a way that hopefully this is even more clear. And I call these the 10 key criteria for soft tissue stability around implant restorations. And I've put this into 2 groups. One group is the biomaterial group. So those will be the implant components, those will be the abutments, those will be the different designs of abutments and materials. And then I have a second group, which is really the procedural group, which is what we do in practice. And I'll go through all of these step by step. So let's start off with the components first of all. Well, implant surface, number 1. We know today that an implant surface affects bone stability and bone integration. So, and this goes from the apex of the tip of the implant all the way to the neck. So it's preferred today that an implant has a micro roughened surface all the way to the top. So it can maintain bone the whole way, but especially around the neck of the implant where it's supporting bone, and of course then stabilizes soft tissue. And you can see here some references. Point number 2 is really the implant neck design of an implant. And you can see that over the last 20 years, we've had like a little shift. And the shift has gone from implants where it had a wider neck, like the traditional Brandenmark, where we use the countersink burr. We've gone to something straight, like you see here, the Nobel Replace, which is a straight neck. Or we go even to something like an Nobel Active, or today you could also have an implant like a Bicon, or even an ankylose, which have an internal connection, which then brings in a better bone stability and better soft tissue stability. So, and again, this is new information, but certainly it makes me choose today, in my soft tissue important case, more the implant in photograph 2 and 3 than the implant in photograph 1. Then we go to point number 3, which is the abutment materials. And today I think it's very clear from a standpoint of studies we have, as well animal as well as clinical patient studies, that the materials of choice are really titanium and zirconia. Those are the 2 materials we like to use. So basically, those have good soft tissue health. They promote soft tissue health. They also prevent a lot of bacterial accumulation. And also they have the precision which we need to connect to our implants. So that's very good. So basically, we try to prevent plastic abutments. We try to prevent gold alloy abutments. And we maintain the titanium and the zirconia. And then, of course, it's also important to say that the design of these implants is important. So you can see that the margins which we're bringing into them needs to be higher. So a margin where it meets the crown really will be per gingival. Could even be supragingival a little bit, or it could be slightly subgingival, but never deep. So that's very important from a standpoint of soft tissue health. And that takes us to point number 4. And point number 4 really presents, again, the idea of what do we do with an abutment? What is the proper design? And we know today quite well that the subgingival space influences soft tissue stability. So we like to be in this space with a reduced diameter. So you're looking at an abutment, it has to be like concave, or it has to be reduced. And that's what we call today platform switching, or platform shifting, or we go internal into the implant. So it's a concave connection. Also, we like to again bring the shoulder of the abutment higher up. We like to go again per gingival if possible. So there's no potential for cement rest to be left subgingival, because this causes again inflammation, it can cause peri-implantitis, and it can cause failure. So that's very important, that the shoulder of the abutment is taken all the way up to the gingival level so it connects there properly. So this is the abutment design. And here you can see it, a case which we did, and you can see it quite nicely, an abutment. This was just a healing abutment. And then we're placing, in this particular case, after proper soft tissue healing, this zirconia abutment, which we made CAD-CAM. And you can see here the fabrication of this here and the insertion. And you can see when this crown now gets cemented in this single tooth application, that there's really minimal displacement of soft tissue. And before we cement this, we even put in some cords so we can then remove the cement rest very easily from this area, and we have no risk that the cement rest move apically into the space. And here you can see a very proper soft tissue dimension in this patient. So then we come to the last point with components. And here's where we have to think about when we use components, and when we choose components, and now we start to use them in practice, when do we do this? And do we use temporary abutments or do we use final abutments? And really the idea is here to go to the studies which are discussing the influence of changing abutments on bone and soft tissue. And we know today that the more we switch abutments, the more we introduce inflammation in soft tissue and introduce bone remodeling, which is going apical, so bone loss. So the goal today is to choose and pick your final abutment as early as possible, place it, and don't switch it, if possible. And that produces then, as you can see here in this clinical case, two center incisors, which really show you not only a very proper gingival margin, it also shows you a very beautiful gingival papilla, and that's between two implants. And here you can see the radiograph. And this was actually done on two implants with a hex connection, so these were Brandenmark implants, and an alumina abutment. But you see the alumina abutment was like nice and gentle in its form, subgingival. The connection was at the pergingival level, and we're able to connect this. So quite a beautiful demonstration of no abutment connection or reconnection, and stable soft tissue margins and stable bone margins. Now let's take this to the next case, very similar. Two center incisors, but now what do we see? We see here soft tissue recession, we see here gingival papilla loss, and we see here some zirconia abutment visible. So, and when we look at this here in the radiograph, you can see here what happened. Number one, the design of the abutments was really too wide. It's too bulky. So it's already like, pressing on that very delicate soft tissue. Secondly, we tried, because we didn't really know at this time, this is more than 10 years ago, we tried to stimulate the soft tissue to grow more coronal. And we switched these abutments several times and added some material to it, and it just didn't work. It made it actually worse and worse. So the idea today is, as we know where the implants need to go, we know that 3 mm rule, let's take an abutment which has the proper design and place it as a final abutment as early as possible. And that really with minimal reconnections. So this completes our components. Now let's go to procedures. I mentioned this already from a standpoint of gingival papilla. It's very, very important to space our implants and to space our abutments correctly. So think about always that the space between implants and adjoining structures, it needs to be sufficient. So between a tooth, at least 2 mm, between implants, at least 3 to 4 mm. And you also have to think about leave space between the abutments and the crowns, so the soft tissue can fill in. So leave an embrasure space. So this is what the implant spacing does today. They really give us that option to control bone and control soft tissue. Then we go to point number 7, and here you can see how implant positioning, especially the vertical position, plays a role. And I demonstrate here through this case where I have the very good surgical guide stand made. You can see that the surgical guide stand gives me that contour, which is the proper contour of the final crown. And I've placed the implants in exact reference to that gingival margin. So it's approximately 2 to 3 millimeters below this. But now, of course, I have titanium exposed. So that's why you see on the right photograph, I placed here an autogenous particulate bone graft. I covered this with a non-resorbable GBR membrane and allowed this to heal uneventful for 6 months. And now you can see, after 6 months, I have built back and regenerated back a new bony foundation, which covers all the titanium. And this new bony foundation now will be the new level of bone where I can grow 3 millimeters of soft tissue on. And that gives me then the proper contours, which you see on the right side. So implant vertical position and bone grafting often go hand in hand. And it sometimes needs to be biological grafting, like you see here, and sometimes it can be functional grafting by just using a bone filler, like a xenograft, which then supports the soft tissue. Then we go to point number 9. And point number 9 really is not a soft tissue grafting. And it's funny that in this 10 key criteria, which is about soft tissue, not till we come almost to the end at point 9, I speak about soft tissue grafting. So you can see there's so many other factors which play a role before we really get to grafting of soft tissue. But soft tissue grafting is important, and you can see here that we've had studies over the years. We started in 1997, and we've published them even up to a few years ago, that when we add connective tissue grafts to our implants and to our bone grafts, we can basically change the volume from thin to thick. And that's what you can see here. So, and connective tissue grafts are usually taken from the palate, where we take them either from the zone between the first molar and canine, or we take them from the tuberosity area for augmentation of soft tissue volume. And we have a beautiful study here, which was published by Urban et al. And we published this in the JOMI in 2009. And we evaluated what's the complication rate, really, if we do soft tissue grafting. And it was interesting that when we added connective tissue grafts to our bone grafting procedures, we had 0% complication rate in this group of patients. But even more interesting was that when we added connective tissue grafts to the cases, that we actually had quite a nice and better bone stability than if we didn't use it. So adding connective tissue adds volume, so it increases the biological width, and that reduces the amount of bone loss. So that's a good reason for us today to present this to patients, so we can tell them there's a more predictable soft tissue margin. So that's soft tissue grafting. And then we come to the final point of soft tissue, and that's really the temporary. And anytime you work with edentulous spaces, anytime you work with soft tissue margins, we need to have a type of temporary and a type of abutment which really allows soft tissue to mature and also soft tissue to fill in to those embrasure spaces. And you can see, depending on which study you analyze, you can actually temporize implants for up to 1 year, and you can still see soft tissue and papillas to form. So it's very beneficial for us. And you can see that here in this particular patient. This was the single tooth temporary, very beautifully done here. And this one we left in place for 6 months, and you can see how the soft tissue margin in this lower anterior is almost perfect. And this is the final, which was done by the brothers Pascal and Michel Magne. And you can see that, first of all, the ceramic is beautiful, but also the soft tissue margin is very well developed. So again, proper protocol, implant position, proper augmentation with bone and if needed soft tissue, and then proper temporary and final can really give us this spacing and this beautiful development of soft tissue. So these here then can allow us success and predictability with patients. So this concludes the 10 key criteria which you can review and kind of use as a checklist almost in your patients. And we can't do this perfect for every single patient. Every single patient is a little bit different. and we can't always make this possible, but we can do a lot of them and hopefully be predictable. So now, using these 10 key criteria, I would like to present a couple of case examples to you where you can see that in patients. And the first case example that I would like to show you is one where I use those 10 key criteria in a patient where we don't need to do much augmentation. We're just preserving tissues. So here's the patient. It's a patient who is missing, or is going to be missing, 2 central incisors, and I have to extract these teeth. And we're going to have to place implants on a minimal invasive procedure. So we're going to use minimal invasive procedures to really get this done. Let's have a look at this. This is the patient from start to finish. You can see here the implant placement. You can see the radiograph. You can see here the final aesthetic crowns, and you kind of see, hey, this soft tissue, the buccal margin, the papilla margin, it all looks good. So how did we get there? So let's look at this patient first. First, I see here a good gingival mucogingival level, so it's thick. Secondly, I can see good bone levels. But why did the patient need help? Well, here you can see. In the meantime, between those 2 x-rays, there was a traumatic injury which happened to the front teeth, and this caused extreme external resorption. And this is what you see here. We took a J. Merida scan and showed that we had good buccal bone plate. We had no perforations, we had no pathology except for internal in the tooth, and we had a good skeletal relationship of the tooth in the implant position. So we can maintain this bone. Then I started to extract the tooth very carefully, but because of this aggressive problem the patient had, the tooth came out in many, many pieces. So although my plan was first to do an immediate implant placement, I changed the plan and only chose to use socket grafting. So here you can see my socket graft. I placed this after I really degranulated everything. I cleaned out the sockets, I cleaned out all the soft tissue, and I preserved the buccal bone. I placed here 100% xenograft because the buccal bone plate is intact. Then on top of that, I place an alternative to soft tissue grafting, which I sometimes use for socket grafting, which is a thick 2-layer collagen membrane. The commercial name is Mucograft. And this one I can use just kind of as a plug, so almost like an ice cream plug. And I place this on both of the sockets on top of the bone. And basically what this will do, it will stabilize the soft tissue margin. And you can suture these into place into the soft tissue margin, because I want to maintain that 3 mm height. And you can see here then after the period of 4 weeks and 6 months, how now we have preserved completely the mucogingival line. We haven't lost anything. We have preserved the interproximal papilla, and we have here really good conditions. So now I'm ready for implant placement. I might go with flapless, or I might go with incision. So I need to take one more x-ray. So I take here the second J. Merida scan, and I'm looking at the amount of bone I've achieved, and I have preserved all the bone. So I have here close to 7 to 8 millimeters of bone, so I could do flapless. So the choice now is to go minimal invasive, and here it is. I'm using a surgical guide stent to place these implants, and my choice is to use the reverse neck, Noble Active, regular platform, so we're reducing the amount of space occupied by implants, and you can see the amount of space between the 2 implants and the implant insertion. This will really give us a good horizontal spacing. Then the vertical spacing. Placing the implant in the proper vertical position. Here I'm placing it deeper than normal. I'm placing it at 5 millimeters. And the reason behind this is that actually in this particular case, what I'm doing is deepening the implants a little bit because the implant has short teeth. And those short teeth can kind of be improved a little bit by surgical crown lengthening, which we'll do then later. So here I'm placing the implants slightly deeper with the idea that we want to lengthen this at a later time. So implants are placed. They had a stability in the bone of more than 40 Newton per centimeter, so I can do immediate temporaries. And I'm choosing here at this moment aesthetic 3 millimeter titanium abutments. They're stock abutments. We're modifying them slightly outside of the mouth, but in the clinic. and then we're placing shells of the acrylic temporaries, adapting them with some acrylic, and finalizing them in the clinic for cementation. And you can see how they have been connected, they have been reduced, so there's no occlusal contact, there's also no protrusive contact, so this is only like as a temporary. And the patient continues with this here for at least a month of 3 to 4 months. In this particular case, we went 4 months. And then you can see after 4 months how the soft tissue margin actually really reacts to this here beautifully. Minimal invasive, the temporaries were well designed, we left that interproximal space, and you can see how the soft tissue comes in. And the papilla now between the two centrals is, if you look at it, is at a proper height. It's actually even higher than the lateral incisors. So that's what we'd like. So the next step we will do now is to say, okay, we need to think about the smile design of the patient. So these teeth are too short, so now we can lengthen it. So after about a 4 months minimum, we'll go back in, leave the papilla as it is, and we use a laser to just do a gingivectomy in the implant sites. And also we did a little bit of a gingivectomy around the lateral incisors to lengthen this, and we didn't need to remove any bone because the teeth had a passive eruption, so they were just covered with gingiva. And we could do a gingivectomy because there was sufficient keratinized tissue here to start with. Then I'm just making one switch, and then we switch from titanium to zirconia. This is a 3 millimeter zirconia aesthetic abutment for the Noble Active, and it's a straight abutment, so the implants were in good position. And I'm just switching it because the tissue was getting a little bit thinner, and I didn't want to have the risk of the titanium shadowing through. So I made one switch here in the abutments, but this will be used now as a final abutment. And then we had a laboratory technician available to us here who modified this directly for us on the same day. And then you can see how these abutments have been modified, again, to just be supporting the soft tissue properly. We're using the platform switch and also supporting the interproximal soft tissue and having a margin which is right there at the gingiva. And then here comes the full contoured temporary crowns, leaving embrasure spaces for the papillas between the incisor and the centrals and between the centrals. And you can see a little bit here the tissue margins which we modified during the laser. This is all done on the same day. And properly you can see it in how we did this. Now notice what happens over time. This is approximately, again, 4 months later. You see a good maturation of tissues, the soft tissue margin good, the soft tissue papilla good, and a really nice smile which was developed now in this particular patient. So now we can go and move to the next step, which basically is, if we need to, final impressions, which were taken from these abutments. We basically just place some cord, usually 2 cords, into the gingival sulcus, and then take a final impression of these abutments. And if we need to modify a little bit, we could do this as well, just chair side. And then final crowns are placed, and you can see here then in this particular patient, the final crowns done here by Dr. McLaren, a beautiful cemented into position, and the 2 lateral incisors also beautifully done here. As you can see here, everything looks very, very natural. And here's just the before and an after. This is like the temporary stage. And you can see how we use that temporary stage to preserve all the tissue. And then if we need to, we can contour it in a situation where like it gets to really this optimal aesthetic contour. So this shows you how all key criteria were used in a proper fashion in this particular patient. And here was before. So I would almost say that this patient can be happy with this internal resorption he had, because the crowns look better than his natural teeth. Next example I would like to do when we move a little bit more towards augmentation. And you can see here in this particular patient how we're going to look at tissue preservation, but also some soft tissue augmentation. And you can do those 2 things at the same time. And the case study will be a patient where we have to extract 4 anterior teeth because of a hopeless condition of them, having short roots, some periodontal attachment loss, as well as some mobility to those anterior teeth. But we're going to augment the site with a pouch connective tissue graft. And here you can see it. Here's the condition of the patient. You can see here she has some generalized recession. She has the 4 anterior teeth, which were crowned already. They're all slightly mobile, very short roots. And she also has some blunt papilla between the central incisor and some very thin tissue on the tooth number 9. But the buccal bone wall is intact, and the patient is looking for a minimal invasive procedure. So the goal will be to extract teeth and place 4 implants, use the bone she has, the buccal bone she has, but improve the soft tissue by just grafting the buccal soft tissue. So you can see that here. So here's first step. First step is to place 4 tapered replace implants. 2 narrow in the laterals and 2 regular in the centrals. Then, as you can see in the right photograph, we're grafting the gap between the buccal bone plate and the implants with a xenograft. But now we're focusing on really this soft tissue, which is thin on the buccal of number 9 and interproximally. So what can we do? Well, there is a technique which we've been doing in periodontics for many years, and that is using no incision, no vertical incisions, and use tunnel or pouch procedures to really slide connective tissue grafts very elegantly and also very minimal invasive into areas. So you can see how on the left photograph I moved one of my instruments, this was the Joe 1, into the sulcus and separated the flap from the underlying bone or from the underlying periosteum preferably. And with this instrument I'm making a little pouch. Then I went to the palate, harvested a connective tissue graft of the proper dimensions, and then I used sutures and as well as instruments to slide it into this pouch and to augment it. And as you can see in the right photograph from the occlusal, I have built up now the soft tissue on that number 9, number 8, and number 10 area. And this horizontal dimension will also usually give me like a little bit of an advantage vertically. So here you can see then the healing 6 months later. Beautiful. This is just a mirror shot, so you have to kind of see it flipped over. So number 9 and number 10 is right here. And you can see how actually the augmentation has turned out to be even better and the soft tissue thickens than it was on the original tooth. So really you can change a thin gingival biotype into a thick gingival biotype by this internal grafting in these particular patients. Then we use the proper abutment design, which you can see here, and with good technician help, and this was done fabulously by master technician Michel Magne, where you can really see how he maintained that shape of the teeth properly and really moved it into a really ideal shape and condition so the soft tissue can grow in. And this allowed us then with the final to come into this shape where like you can really see that soft tissue grow in there and it wants to move in the right direction. And that's really the key in temporaries as well as in finals, to give the soft tissue the potential to grow in there. And here's the final, where you can see really 4 beautiful teeth and very healthy soft tissues with a bone stability which shows crestal bone stability around these 2 implants which we grafted. And here's Michel Magne working on the patient, or just like looking at the crowns I should say, in this particular patient, and we're all happy with this final very natural aesthetic result. Okay, my last case example is really here when we look at bone augmentation, soft tissue augmentation, and potentially periodontal regeneration. And here we come into like the question of when do we potentially sometimes have to use other supplements. And tissue engineering, as we have it today, is becoming more and more important for bone regeneration. But it's been already important for periodontal regeneration. And there's particularly a product called Emdogain, which is of really excellent use to get new periodontal attachment. So we're using this for particular cases where we want to increase and achieve accelerated wound healing, but we also want to achieve a better periodontal attachment gain or attachment support. So that's what you will see here. So the patient I'm presenting to you is one which has a missing canine. And this missing canine particularly is not easy, because you can see here that this missing canine here has bone loss, it has soft tissue loss, so normally that would be already calling for ridge augmentation and soft tissue augmentation, but you can also zoom in on the distal of the lateral incisor and on the mesial of the first premolar. You can see how soft tissue was lost there. So for me to bring this down, so in a coronal position, I need to think, how do I do this? And of course I can coronally reposition the flap, but will it be stable there? And that's why we use a supplement like a growth factor in this particular cases. So let's look here, and this is the result. Notice here how in the final result, I was able really to bring the soft tissues down. Here was the beginning, so this was the before, here's the after. And look how I was able to really get a result for this patient which was quite stable and quite successful for the patient. So how do we do this? First, we analyze the patient's conditions. Our restorative team, in this case was Dr. Stefan Paul, made a beautiful surgical guide stand, and I placed the implant at the proper bone level. So, meaning 3 millimeters below the ideal gingival margin. I'm missing bone here, there's no buccal bone, there was also no vertical bone, so I grafted autogenous particulate. I placed a non-resorbable GBR membrane. And then on top of the non-resorbable GBR membrane, I placed a free connective tissue graft, which you see here. And it's like a saddle graft, so it has the proper dimensions, harvested from the palate, so I can wrap it from buccal to crestal to palate. But then I'm adding one more tool, and this is a tissue engineering tool. And you can see here, some of the studies from Rasparini particularly are excellent here. And Giulio has done some great work here with Emdogain, because he has shown us that you can get actually periodontal attachment stimulated from the periodontal space. So this Emdogain is only used around the teeth. It's not mixed with the soft tissue, it's not mixed with the bone, just around the teeth to stimulate periodontal ligament cell development. So we're going to try to get new attachment, we're going to try to get new cementum, we're trying to get new also bone if possible. All this potentially possible over about 1.9 or 2 millimeters, but that's all we need really in these cases. Now sometimes from a clinical perspective, I use something which is really non-evidence based, but still I think it helps me. I use some of this Emdogain also on the soft tissue, and I just like inject it over it like a gel, so it accelerates wound healing. And then we close the flap, and you can see after 14 days, an excellent healing, a coronal positioning of the flap, really in a condition that it's now imitating, again, the original papillas and original soft tissue level it was before. There was so much soft tissue here that actually I had to ask Stefan to cut back the temporary more. And that's what he did here, and that's what you see in the second photo. And if you compare this condition with before, you can see how we were able to really drop the soft tissue margin coronally or down, and also how we were able to bring the soft tissue papilla back quite nicely. So now I just have one problem, and that is that I don't want to raise these newly regenerated papillas, so I have to come up with a new incision. So this is where I came up with this remote tunnel incision technique, which you see here. And the remote tunnel incision technique is basically accessing the crest without touching the adjacent papilla, and then making an apical incision, and those two I can tunnel. And then I can remove titanium tacks like the ones I had here. I can remove a PTFE membrane, which I had here. I can remove a cover screw, and I can actually bring in an healing abutment. I can bring in an impression coping, or I can bring in immediate temporary. And that's what we did. Stefan was available chair side, so what he did here, make an screw retained immediate temporary, and you can see how he had this beautiful subgingival space, and he left the spaces interproximally, so we had embrasure space to fill in. Then after about 6 months, we made the finals. And then you can see here, specifically when you go to the final on the right side of the photographs, a 1-year loading, how the soft tissue can even creep in. So you have here a proper soft tissue margin on the facial, but we even have a full gingival papilla on the meso and on the distal of that single tooth. So quite impressive to see how soft tissue likes to develop if you give it the foundation and if you give it the right restorative means. So here post-operative 1 year and the pre-operative as a comparison. And then here you can see the final result in this particular patient and think where it started from, and you can see almost like a perfect gingival margin from a standpoint of canine to central relationship and how deep it was before. So now we have come to the end of the lecture, and I would like to pretty much conclude on the fact of using the protocols we know, which is basically our clinical protocol to position the implant in the proper three-dimensional position, work with that ideal vertical position because of the soft tissue dimensions we have. If needed, you have to think about ridge augmentation. And if needed, we have to think about soft tissue grafting. This brings us really an optimal soft tissue dimension. And then, of course, also use the 10 key criteria and use them as applicable in your patient. And never forget, of course, that the patient is also one major part of our treatment, and select the correct patient with the correct, really also, wishes to support this type of work. So I hope that all this information is well digestible for you and is usable in your practice. It has helped me a lot in the last 14 to 15 years to really now able to control the soft tissue margin. Thank you very much.
For more education programs, visit the Guide Institute at www.guidedental.com.